Okay, so good morning, everybody. I'm Victoria Lancey, and I'm the Rural and Education and Communications Manager for Michigan Center for Rural Health. And I would like to welcome to everybody today to our MACRA, MIPS, and APM's education series. Our topic this month is Understanding MIPS Cost Category. Just a few reminders, if you're logged into the webinar portion using the link provided, you can listen to the audio through your computer speakers. If you are participating via the phone number, then don't worry, we are recording each webinar. The recording will be posted on our MCRH website, which is www.mcrh.msu.edu. Click on the resources tab across the top, then under there, click the QPP dropdown. If you would like to ask a question, you can type it into the chat feature, or you may ask it during the Q&A component at the end of the webinar when the lines are muted. With that, I would like to introduce our speakers today from Hall Render, Heath and Lyman, Lisa Lucido. Go ahead and take it over.
Thank you so much, Victoria. Good morning, everybody. Today we will be talking about the MIPS cost category. So let's set the agenda for our topic this morning. So today we're hopeful that you will be provided with a high-level understanding of the MIPS cost category requirements. We'll first start out by discussing the two different cost measures that are comprised of the MIPS cost category. We'll talk about how data is submitted and collected by CMS. We'll also walk you through how this performance category is scored, and we'll give you some examples of that. And then finally, we'll wrap up the presentation by talking about how you may be able to maximize points in this performance category. So just to set the background and remind everybody about the MIPS program, as you may know, the MIPS performance program is comprised of 4 performance categories for performance year 2018. There are 100 possible final score points that you can earn under MIPS, and each performance category has its own specific weight or point assigned to it. So those points are totaled up to get to the 100 possible final score points. And based on your total performance score, you will either earn a positive, negative, or neutral payment adjustment to your Medicare Part B professional payments. And so as you can see, the cost category is worth 10 out of 100 of your MIPS points, or otherwise known as 10% of your overall MIPS performance category score. So why is CMS focusing on cost? Why does this matter? So CMS has noticed that over the years, healthcare costs have continued to increase substantially, and Medicare is really interested in trying to cut back on those costs and find ways to improve quality and patient outcomes at the same time. One of those ways to do so is through this quality payment program and the MIPS program. And so CMS is hoping to improve care transitions and care coordination across multiple care settings. As you know, some of your patients might be chronically ill or may end up in a hospital admission and may need post-acute care. And so really what the goal of the MIPS and quality payment program is trying to do is trying to improve quality outcomes and coordination of care across those different provider types in hopes to reach better outcomes for patients. CMS's goal for the cost category is to align cost measures with the quality of care. And the goal is to work towards better patient outcomes, smarter spending, and rewarding providers for effective care delivery and reducing delivery system fragmentation. So let's start out with some background on the cost category. So you may be familiar with the value-based payment modifier program. The MIPS cost category is essentially replacing that particular program under PQRS. So for performance year 2017, CMS did not score the cost category. Providers participating in MIPS in 2017 actually earned a score of 0. The cost performance accounted for 0% of your MIPS final score. So cost was not evaluated for the prior performance year. However, for this year in 2018, CMS is scoring you on cost. And so you will have a maximum potential of earning 10 points. It accounts for 10% of your MIPS final score. But if you are participating in a MIPS APM, cost will continue to account for 0% of your final score, and CMS hasn't changed the MIPS APM scoring standard for cost for 2018. So just please keep that in mind if you happen to be participating as a MIPS APM. And another reminder about the cost category is that you are evaluated for a 12-month reporting period on this performance category. So in future years, for 2019, 2020, 21, and beyond, CMS will establish the weight of the cost category in final rulemaking. So for now, for 2018, it's worth 10%, but in the future, it may be worth more. In fact, due to statutory changes made by the Bipartisan Budget Act of 2018, the weight assigned to the cost performance category must be between 10 to 30% in the third, fourth, and fifth years of MIPS. So in the future, this particular performance category might be more heavily weighted than it currently is. So please just keep that in mind for future reporting years. So what data does CMS use for measuring the cost performance category? You might be happy to find out this is one of the most easy and streamlined ways to submit your data. In fact, you actually don't have to do anything. So CMS will use data from your Medicare Part A and Part B claims with dates of service from January 1 to December 31st, 2018. So that's known as the performance period for this reporting year. You don't need to take any separate actions or submit anything special to report on MIPS for this particular performance category. All you need to do is just continue to see your patients and submit your Medicare Part A and Part B claims as usual. So no separate data reporting mechanism required, unlike some of the other MIPS performance categories. This is very straightforward. CMS is just pulling cost data based on your regular claim submission. So CMS will analyze and evaluate your cost data by using your individual MPI if you're participating in MIPS as an individual, or your group payer tax ID number if you're participating as a group. Individual clinicians are identified by a unique tax ID and MPI. There are two cost measures for the 2018 performance year, and the first is known as the Medicare spending per beneficiary. And the second cost measure is known as the total per capita cost, and that will be for all attributed beneficiaries. And we'll go into further detail in the next few slides about each of the different cost measures. It's important to note that both of the cost measures are accounted for and averaged in your final MIPS score for cost. So what is the total per capita cost? This is calculated from all of your Medicare Part A and Part B claims during the MIPS performance period, so that's January 1 through December 31st, 2018, based on patients attributed to you or a clinician or a tax ID. So patients will only be attributed to one clinician or tax ID using the level of primary care services that were received and the clinician specialty that performed the services. The Medicare spending per beneficiary cost measure is a little bit different. It's calculated based on what Medicare pays for services performed by an individual clinician or a tax ID during a Medicare spending per beneficiary episode. So different than the total per capita cost, this is limited to a particular episode, whereas the total per capita cost measure is measured over the entire performance period. The Medicare spending per beneficiary per episode window includes a period of 3 days prior to an index admission, which we'll talk about in the next few slides. Spending is evaluated during the episode and also includes 30 days of post-hospital stays. So that accounts for the entire episode. So let's talk a little bit more about the Medicare spending per beneficiary, otherwise known as MSPB. So CMS will use MSPB to assess the cost of Part A and Part B claims during an episode, which, as I just explained, is that period, that 3-day period immediately before, the period during, and that 30-day period after a patient's hospital stay. An episode is defined by CMS to include Medicare Part A and B claims falling in the episode window. And as I mentioned, an MSPB episode will span the dates 3 days before an index admission to 3 days after a hospital discharge. An IPPS, or Inpatient Prospective Payment System, hospital admission will trigger an episode where a cost is going to start being calculated, and these IPPS hospital admissions are known as index admissions. So as you can see, this slide just kind of outlines where the episode will start and where the episode will end. So we have that 3-day prior to the index hospital admission. So all Medicare Part A, Part B claims are included the 3 days prior, all of the claims that were accrued during the admission, and following discharge that 30 days after discharge are also included and calculated for purposes of cost. So as I mentioned, all of Medicare Part A and Part B claims for items and services provided to the beneficiary during the episode window are included in an MSPB episode. And those will include some of the following claim types: inpatient hospital, outpatient services, any skilled nursing facility services, or home health and hospice services, in addition to DME and non-institutional physician or supplier claims. So this is just other Part B carrier claims. All of these claim types will be included if they fall during that episode window. Another key factor for evaluating costs for the MSPB measure is attribution. So for MSPB, CMS will attribute each episode to the clinician who provided the most Part B services in terms of dollar amount of Medicare allowed charges during the index admission. In the case of a tie between two providers or multiple providers who provide services during an episode, the episode will be attributed to the clinician who has the highest count of Part B services. CMS will attribute episodes at the individual clinician level via the clinician's tax ID or MPI. However, those who participate as groups will have a single score for their group based on combined data. So just a difference between whether you're participating as an individual or a group, how you will have beneficiaries attributed to you for this cost measure. Another key factor for the MSPB cost measure is the case minimum. So you have to have at least 35 episodes attributed to you to be scored on MSPB. You will not be scored on this cost measure if you have 34 or fewer episodes attributed to you, or you did not bill any Part B services in hospital stays during the performance period. This slide contains a lot of detail, and I won't go through every single exclusion, but it's more for you for informational purposes to reference back. This is the comprehensive list of all of the different measure beneficiary exclusions for MSPB. So certain beneficiaries will not be attributed or counted for purposes of measuring MSPB in the cost category. Some of those examples include if a beneficiary died during an episode, if the beneficiary wasn't continuously enrolled in Part A and Part B for 93 days prior to the index admission, and things of that sort. So there's a couple of different beneficiaries that will fall out of this particular cost measure, and it's important that you are aware of some of the exclusions. So the next measure that comprises of the cost measure performance category is known as the total per capita cost, or TPCC measure. So CMS will also score you on this measure, and they use the TPCC measure to measure all of the Medicare Part A and Part B costs during the MIPS performance period. So different than MSPB, this is broadly covering the entire MIPS performance period, whereas the other cost measure evaluates only during the episode window. For the TPCC measure, beneficiaries are assigned to a single Medicare clinician tax ID MPI in a two-step process that considers both the level of primary care services the patient received, as measured by Medicare allowed charges during the performance period, and the clinician specialties that perform the services. Again, similar to MSPB, CMS requires attribution for this cost measure. So TPCC assesses all Medicare Part A and Part B claims, and attribution is a two-step process. So CMS will attribute a beneficiary to the tax ID or MPI who provided the most primary care services based on a large allowed charge amount for primary care physicians, NPs, PAs, or clinical nurse specialists. If a beneficiary is not attributed in step one, CMS will attribute the beneficiary to a tax ID MPI who provided the most primary care services based on allowed charge amount from the non-primary care specialist. And it's important to note that CMS defines primary care services to include E&M services furnished in an office and other non-inpatient, non-ED settings. They also include initial Medicare visits and annual wellness visits. Beneficiaries who do not receive any primary care services will not be attributed. And in the case of a tie between multiple providers, an episode will be attributed to the clinician who most recently provided services in cases where two clinicians are tied. Again, similar to MSPB, there is a case minimum requirement to this measure. So in order to be scored on the TPCC measure, eligible clinicians and groups must have at least 20 different episodes attributed to them. Clinicians and groups with 19 or fewer episodes will not be scored on the TPCC measure. And again, just friendly tip and reminder, remember that you don't have to submit any special data or reports for the cost performance category. All you need to do is just to continue to see your patients and submit your Medicare Part A and Part B claims as usual, and CMS will collect that data and assess you based on that data. So again, there are some exclusions to this performance category as well. So Medicare beneficiaries that are not enrolled in both Medicare Part A and Part B for every month during the performance period will be excluded unless part year enrollment was a result of new enrollment or death. Beneficiaries are enrolled in a private Medicare health plan for any month during the performance period, they will be excluded as well. And any Medicare beneficiaries that have resided outside of the United States during any month of the performance period will be excluded from the TPCC measure. So the cost category is comprised of both of these cost measures, and you are assessed individually on the cost measures, and then your score is averaged. So if you don't meet either case minimum under MSPB or TPPC, your performance on cost will count towards 0% of your MIPS final score, so you won't earn any points in this category. What will happen is then CMS will shift the weight of your quality score, and that will increase from 50% to 60% of your MIPS final score. So if you aren't able to meet the case minimum in cost, your quality score is just going to go up. So it's really important that you do well in the quality category to account for that lost points that you may not be able to receive if you don't meet the attribution and case minimum requirements for the cost category. So let's talk about reporting and scoring for this category. Each individual MIPS eligible clinician and group's cost performance will be calculated using administrative claims data. So again, you don't need to submit anything separate or special. CMS will automatically calculate the cost category based on your claims data. Individual MIPS eligible clinicians and groups aren't required to submit any additional information, as I mentioned, so very straightforward, easy to report in this category. Performance is compared against performance of other MIPS eligible clinicians and groups during the 2018 performance year. So the benchmark isn't based on what you've done in a prior year. You're going to be assessed against other eligible clinicians and groups during the same performance period. So each category, you are eligible to receive 1 to 10 achievement points based on each performance measure. Measures are risk adjusted to account for differences in beneficiary level risks that can affect medical costs no matter the quality of care provided, so that's important to note. And CMS will average your achievement points based on the two measures. So you'll be evaluated both on the MSPB and TPCC measures, and the sum of that will be added and averaged out to achieve your total possible points. So cost performance will be the total points scored on each measure divided by the total possible points that are available in this performance category. So let's walk through a quick example of how this might work. So let's say you have 20 episodes that are attributed to you for the MSPB measure, and you have 20 episodes attributed to you under the TPCC measure. Which, if any, cost measure would your score include? So in this case, your score would only include the TPCC measure because you're below that 35 case minimum for being scored on MSPB. So you wouldn't be eligible to be scored on MSPB, but you do meet the 20 case minimum for being scored on TPCC. So you just wouldn't earn any points for your MSPB measure, but you will be able to meet that threshold for TPCC. So this slide walks through another example of how this might work, and for purposes of this slide, we're going to assume that you meet the minimum case thresholds for both TPCC and MSPB. So as you can see, each cost measure is worth 10 total possible achievement points. This particular clinician earned 8.2 for TPCC and earned 6.4 points for MSPB based on their claims data. So that's a total of 14.6 measure achievement points out of the total possible 20 points that that clinician would be eligible to score in this category. So 14.6 out of that total possible 20 points is 73%, or 7.3 points towards your MIPS final score out of the 10 points that you were eligible to earn in this particular category. So I wanted to remind you of some key takeaways for this particular performance category. So important to keep in mind that the cost category is comprised of the average of the MSPB and TCCP measures. So you will be evaluated on both measures, and if you're not able to meet the requisite requirements to be scored on one measure, that's okay because you can still earn points on the other measure. The MSPB measure requires clinicians to meet the minimum case threshold, which is at least 35 reported episodes. And then remember, for TPCC, that measure requires you to meet the minimum case threshold of at least 20 reported episodes. So important to keep those minimums in mind to be scored. If case requirements are not met, the cost category is reweighted to 0% of your MIPS score, and that quality category score will increase to 60% of your overall total MIPS score. So very important to keep in mind, as I mentioned earlier, focus on quality as well. There's not much you can do in terms of trying to contain your costs. We want, obviously the goal CMS would like you to do is to try and keep costs down as much as possible with delivering the best patient care. However, sometimes your costs are your costs and there's not really much you can do. So it might be important to consider focusing on improving quality, especially since if you aren't able to meet the case minimum thresholds, quality will be a larger portion of the pie for your MIPS total final score. So tips to maximize points in this category. Obviously, there's nothing additional you need to do. We just want you to continue to see your patients and submit claims as usual. No additional data is required to be submitted for the cost category. So from an administrative perspective, this is a much easier category to report on because it really doesn't require much of you to do anything at all, which is helpful. We do recommend that you document complex cases. Remember that CMS will adjust scores for risk to account for differences in beneficiary level risk that can affect quality outcomes or costs. So good to know that if you just happen to have a chronically ill patient population or a patient population that's just high risk, CMS will adjust your score to account for that. So important to keep that in mind. To enable you to provide more accurate comparisons across clinicians and groups that treat levels of varying clinical complexity, CMS will adjust for health and other risk factors that will affect outcomes that are beyond your control. So important there, you don't need to worry if you just happen to have a chronically ill patient population. CMS will take that into account and adjust accordingly. Another tip is just to be sure your ICD-10 coding and other documentation thoroughly detail clinical complexity of the diagnoses that you're treating. So just make sure you're accurately coding and detailing in your documentation clinical complexity of these patients so that if this patient does fall under the chronically ill category or has a clinically complex medical background, important to flag that for CMS to take that into account when they're adjusting for health and other risk factors and determining cost. Also, we recommend to avoid, when feasible, unspecified or uncomplicated ICD-10 diagnosis codes if your medical record documentation supports more complex codes. So just be mindful to code accurately and document accurately as much as possible, because accurate coding and documentation is very important for assessing cost in this particular category, because CMS is just going based off of your claims data. So very important to document as much as possible and use the most accurate diagnosis codes when you are submitting claims. We also suggest that you review prior year performance feedback. So even though cost didn't count towards your total score in the 2017 performance year, CMS does provide feedback on your 2017 cost performance if you did meet the attribution threshold for MSPB, TPCC, or both. So would be helpful for you just to go back and see how you did in 2017 to project how you might do in 2018. You may have already been getting feedback from several years on cost measures from the Physician Feedback Program Quality and Resource Use Reports, otherwise known as QRURs. So you can also review those reports as well, just to get an idea of how you might be doing on cost. And with that, that's going to wrap up our webinar today. For next month in October, we'll be talking about virtual groups, virtual group agreements, and MIPS APMs. And then for the next few months in November, December, and January, we're going to walk back through the Advancing Care Information Reporting Performance category, understanding the requirements of the Quality Reporting Performance category, and reviewing improvement activities for category reporting in January. And then February, as we're getting close to that March deadline, we're going to talk about some last-minute reporting issues and developing some strategies for the cost category. And then in March, we're going to wrap it up and review MIPS for the upcoming 2019 performance year. And so just please let us know. Again, here's our contact information. Feel free to reach out directly to Brian Bauer or I if you have any questions on MIPS in general or the cost category. Our phone numbers and emails are available for you below.
Thanks, Lisa. I have now unmuted the line, so if you have any questions, please feel free to type them in the chat box, or you can ask them verbally. Do we have any questions or comments? Okay. It does. Excuse me. It doesn't look like we have any questions or comments, but if you think of any later, please feel free to either email them directly to me or email them to Lisa or Brian, and then they can help you out. Thank you, everybody, for joining us this morning, and have a great day.